Shall I start?
Yeah.
A very good evening to one and all. I cordially, on behalf of Institute of Pulmocare and Research, invite you to our annual conference, that is PULMOCON 2021. Now, I would like to introduce our organizing secretary and organizing president of the event. Dr. Partha Bhattacharya is the founder secretary of Institute of Pulmocare and Research, Kolkata, and is the organizing secretary of PULMOCON 2021. He is engaged in achieving the motto and the institutional principle, that is research, education, and patient care through different innovations and other activities. Dr. Dhiman Ganguly is our organizing president for PULMOCON 2021. He is a devoted academician for nearly 40 years and has a high reputed national and international recognition as a faculty. He has several publications to his credit and a huge experience in teaching, research, organizing scientific events, and social welfare. He has adored the chair of the East India chapter of ACCP and has a presidential position in the Indian Chess Society. I welcome you, sir. I would now like to request Dr. Partha Bhattacharya to kindly convene over the next part of the program. I welcome you, sir.
Thank you very much. Thank you very much. I also welcome all my guests, my teacher, Dr. Behera, my friends, my colleagues, and my juniors, and the audience to PULMOCON 2021. So it is customary to introduce my institute and the PULMOCON to all of you. Regarding the institute, I like to be very brief. We started the institute way back in 2000, in the year 2000, and in last 20 years, it has grown a little, with its motto being kept in total as research, education, and patient care. And we have been trying consistently and constantly. Regarding PULMOCON, this is the 19th PULMOCON annual pulmonary update of the Institute. This PULMOCON started incidentally, but it has become almost regular. And every year it is gaining momentum. It has been so far praised by all concerned. And we feel that it is a hallmark of our activity in the academic front. Well, in today's PULMOCON, as in other years, we have got two very important talks. One oration in the name of Dr. Professor SND, and the other other talk on igniting innovations in young minds. So as a customary, again, I have to say about Dr. Professor SND, because this time we don't have any senior person to take this charge. We usually used to have somebody known to Professor Day, but this year we couldn't get anyone. And last year we had Professor Padmanabhan Balaram, who actually gave the oration, and he talked about how he invented Professor Day. I'll come to it later on. This scientist and son of Bengal took birth near Hooghly, at Hooghly district in 1915. His childhood was not very comfortable financially, so he was supported by his uncle initially during his schooling, and later on by a businessman to go to the medical school. He passed out in 1939 as MB, that time equivalent to MBBS, and later in 1942 he cleared his diploma in tropical medicine. After working for a few years, he went to England to the University College Hospital Medical School, London in 1947. And he returned, completing his PhD in 1949. Joined the Department of Pathology and Bacteriology, Calcutta Medical College in 1949, and became the head of the department in 1955. This is the academic development career of Dr. Day. But the most important part is his activities. In 50s and 60s were the two decades where Dr. Day actually dedicated himself to research with teaching. He was a very good, renowned teacher, but he was even a better researcher. With very little facilities, he dedicated himself to know what is the reason of cholera, diarrhea in cholera. Before that, way back in 1884, Robert Koch visited Kolkata, and he invented the Vibrio cholerae out here only. But Koch's hypothesis did not act to explain the pathogenesis of cholera. It failed miserably, and nobody knew why and how cholera, Vibrio cholerae, how it makes diarrhea and how patients die. So Dr. Day took up the challenge, and he published in 1959 very famous paper named, quote, Enterogenicity of Bacteria-Free Culture Filtrate of Vibrio cholerae, unquote. And he explained that it is not the invasion by the bacteria, it is a secretion of toxins by the cholera bacteria to cause diarrhea. And what is the outcome? The outcome is simple. People could know the reason of the diarrhea that dries the body out, and people die of dehydration. It led to invention later of oral rehydration solution that saved thousands, if not millions of lives, and also the vaccine against cholera. So what happened later on? Yes, as it happens, there was applaud. There was a lot of applaud from all across the world. Big authorities applauded Dr. Day. And I can quote one from Jesua Lederbach, who was a Nobel laureate and who, in fact, recommended Dr. Day's name for Nobel Prize. He wrote, quote, our appreciation of Day must then extend beyond the humanitarian consequence of his discovery. He is an exemplar and inspiration for boldness of challenges to the established wisdom, a style of thought that should be more aggressively taught by example as well as precept. But unfortunately, this great scientist, the great hero, remain unsung in our country itself. And Dr. Padmanabhan Balaram, he brought him to the limelight way back in 1990. And he published one issue of his journal, The Current Science, absolutely dedicated to Professor Day. And Dr. Padmanabhan, in his editorial address, mentioned that it was a serious omission of the time of, he said, of our time, that Dr. Day was not recognized. He didn't get a fellowship, neither any award from any authority so far. I came to know about Dr. Day 14 years ago from a Bengali periodical. And after that, we decided that we should start an oration. And this oration has been graced by many luminaries. And this year, it is the 13th Professor S.M.B. Memorial Oration. We are continuing it, and we try that, we wish that this oration will instill encouragement amongst us and our fellows and colleagues to get involved in medical research. We have a lot of logistic problems, but still what Dr. Day have shown the way, that sheer zeal and innovative acumen, that can be also, that is the most important part of any medical research or any kind of research. With this, I wish to finish my small introduction about Dr. Day. And now I will talk about the Oration awardee, Professor Dr. Digambar Behera, this to the August audience. Incidentally, I'm very lucky, privileged that Dr. Behera is my teacher, both in my post-graduation and in my postdoctoral days. Dr. Behera was born in 1953 in Cuttack district in Khairapanga village, and he had also some tough days in the childhood. He used to go to school barefooted, quite a few kilometers away. He passed out MBBS from SCB Medical College in 1978, and he then went to PGI MER Chandigarh for his post-graduation in internal medicine. And after that, he completed his MNMS in internal medicine, DNB in respiratory medicine, and he joined the Department of Pulmonary Medicine at PGI and stayed there almost the whole length of his career, except for a small gap of 4 years when he went to Delhi and became the director of the LRS Institute of TB and Respiratory Research. And during his period, the LRS had a different shape. He changed the shape of that institute. He's been trained abroad in many big institutes, and during his whole career of 45 years of teaching and research, he has done a huge contribution to the community and the country. He has he has mentored more than 80 postgraduate thesis, both MD, DM, and DNB. He had at least 15 PhD students. He has authored 9 books. Many of them have been printed, reprinted, and new editions came out. Chaptered 45 chapters in different books. He has a list of awards, a huge list. I can just mention one or two from that. He has been given the Public Service Award by the American Thoracic Society in 2021. He got the BC Rai Award in 2004, and this year Government of India has bestowed him with the Padma Shri Award in 2021. We are proud of you, sir. As usual, he is a member of several national and international society. He is editorial board member of too many journals. He is a founder president of Indian Society for Study of Lung Cancer. He has remained the president of Indian Chess Society. He has happened to be task force member of different task forces for different reasons. Expert panel in several universities, expert panel member in several universities, so on and so forth. So talking about him will take much more time, but as a student, I have seen Dr. Behera. He's an astute clinician. He's a very sincere researcher, and overall, he's a wonderful human being. He all along maintained a very cordial relationship with all his students, and those who are his students can only say how wonderful it is to interact with him. and whenever we have anything, any demand of any kind, he has always been very happy to help us, not just in academics, but also in professional career as well. So this is what I know about Dr. Behera. I don't want to prolong the introduction of him. Now I request Dr. Professor Dhiman Ganguly, our organizing secretary, to confer the Oration Award to Dr. Behera. Dr. Ganguly, sir.
Thank you, Parthasarathy. Am I audible?
Yes, yes.
Okay, it gives me great pleasure in conferring this year's SND Memorial Oration Award to Professor Digambar Behera. We have been friends for many, many years now. It's a good occasion for me, at least, to be able to give him this honor. Without wasting any further time, it's a virtual, we are living in a virtual world. I would have been happier to hand over this memento myself, but that's not possible. Over to you, Dr. Behera, for your SND Memorial Oration.
Thank you. Thank you very much, sir, for the kind words. And actually, it would have been my privilege to receive the award in person from you, a person like your eminence. And I always, and the entire chess community, hold you in very high esteem. And thank you, Partho, for the nice words. I think he told also one thing. We are working together at PGI Chandigarh, and maybe that is the reason he told so many things about me. So I don't think I deserve that. But anyway, at the very outset, I pay my tributes to late Dr. Sambhunath De, a great personality. I had heard about him, and before this, I had seen a write-up, and also Dr. Partho told about Dr. De, how even in those days, in the 50s and 60s, I think it is not the machine, but it is the man with the brain, how can break the ice, and such a wonderful thing he has done. Although, of course, many heroes are unsung. That is the unfortunate part. And I am fortunate and lucky to give the oration in the name of that great man. And also at the same time, I am very thankful and grateful to the management of the Institute of PULMOCON and Research for choosing me for this award. So, ladies and gentlemen, a very good evening. And actually, I have decided to talk to you about something about can India end TB by 2025. I think I have put a question mark, but maybe I should not have put that because it is a commitment of the country. It is a commitment of Honorable Prime Minister of the country and the entire program and everyone of us, whether in the private sector or in the public sector, are working towards this, of course, led by our program. So anyway, let me see what I can tell you, and maybe things will come out gradually. But I had this is TB was one of my areas of interest when I joined LRS Institute of TB and respiratory diseases as its director. I had got an opportunity to work with the program more intimately, and I knew the program little more detail, and I am lucky to continue to work with the program even till today. So whatever little understanding I have got, so I'll try to share with you my views. So what we'll do, I think it is important. I like to discuss about, obviously, when we are talking about TB control, we need to know the burden. What do you mean by NTB strategy? Actually, what is the program is doing? What are the various things that includes the diagnostics, the methods, treatment, notification, private sector, drug-resistant TB, and the possible solutions. And then maybe at the end, possibly I'll give you some solution. We know about the key facts of tuberculosis. Worldwide, TB is one of the top 10 causes of death and the leading cause from a single infectious agent. As you can see in the subsequent slides, you see the tragic mathematics. Death due to TB per year in the globe, it is about 1.4 million. And in India, it is about 4.45 lakhs cases. And if you convert that, if you see the India per day, about more than 1,200 people die because of TB, and it is about 51 people every hour, and about 0.85% or roughly 1 person per minute is dying because of TB. So if you see what is the current scenario, you see, this is the global tuberculosis report of 2020. The 21 report is yet to come, that will come in October. You see, in the year 2019, because 2020 gives the figure of 2019, you can see in the world we had got nearly 10 million new cases or TB incidents. And if you convert that, it is 100 cases. And in India, for the same year, it is about 26.4 lakhs of cases. It is converted into the number as 193 per 100,000 population. And that is about 26% of the global burden. I please note that. Similarly, TB mortality is around 1.4 million or 14 lakhs in the world. And in India, it is about 4.45. That is about 32% of the entire global death due to TB that occurs in India. The MDR TB for the year 2019, it is 4.65 lakhs. And for India, the figure is 1.24. Again, you can see the India only alone has about 27% of the global burden of MDR TB. The another important thing that must be remembered, the three important diseases, TB, HIV, and MDR TB, when these three things are combined, the few countries, about 8 or 10 countries, have the high burden of all these three. India figures here for both TB, MDR TB, and TB HIV. As I have told you, this is the TB disease burden. India has 26% of the global burden of TB. Obviously, if you talk of TB control, it is since the 50s and 60s in this country, there are important TB research that they were carried out at the Tuberculosis Research Center, named at that time. Now it is called as the NIRT, and the National TB Institute as Bengaluru. Then since 62, we had a national TB program, but it was not a structured one. when in 1992, it was reviewed how the so-called national TV program is doing. To the horror, it was found out that only 30% of patients, they are diagnosed, and of these only 30% are treated successfully, meaning thereby if there are 100 patients of TB, only 9 of them could be treated successfully. Then in 1993, the pilot began, and then with the time, by 2006, 31st March, the entire country was covered by the program. And at that time, our focus was DOTS, or the directly observed treatment short course. And with the 5 components, you all know: political commitment, diagnosis by microscopy, adequate supply of short course chemotherapeutic drugs, then directly observed treatment, and accountability. You see, but over the time, there is an evolution, both at the global level and also India is doing that, those strategy also. As I told you, the DOT strategy, the 5 DOT strategy I had told you, then in 2006, the name, it changed it to Stop TB strategy, where to pursue high quality DOTs, and then certain other parameters are put. And then in 2014, when we tested some success, then it was decided to make the NTB strategy, so which was envisaged as integrated patient-centered TB care and prevention with bold policies and supportive system and intensified research and innovation. Of course, the previous things were there, but these are the newer things were added up. So this was the Stop TB strategy with the target of 70-85. Of course, it was there, but here it was only by what time we should achieve those 70-85. 70-85 is what? That means we should detect at least 75% of the new sputum positive cases and cure at least 85%. And then for the Stop TB strategy, it was targeted that by 2015 we should reduce the TB prevalence and the death rates by 50% in comparison to 1990. And by 2050, we should eliminate TB as a public health problem, meaning thereby less than 1 case per million population. However, then as I told you, the world moved on, so also our country. So the WHO passed a resolution in May 2014, that is the new post 2015 global TB strategy with ambitious targets. You see, that is now known as the NTB strategy or the NTB. So moving from halting TB or stop TB to ending TB, and the target was 2030. So it was the STB or the Sustainable Development Goal target 3.3 by 2030 to end the TB epidemic. You see, from the MDG era or the Millennium Development Goal era, we moved on to the SDG era or the Sustainable Development Goal era. So from stopping TB to ending TB and ultimately eliminating it, and translating quest for equity and social justice, universal health care and social protection into access to high quality service without incurring catastrophic costs, placing the center that is all people vulnerable to or affected by TB. So person or the patient was the focus or at the center, and then rapid introduction of innovations such as new tools, policies and systems, and all of society approach, which was in the Stop TB strategy. It was not just all government, the society was involved. So in the end, there was acceleration of incidentation and mortality decline of tuberculosis. So we have to now move, or we move towards the new era of SDG, and from Stop TB strategy or from the DOT strategy to Stop strategy to End TB strategy. So what are the vision? The vision of this End TB strategy, which was as envisaged by the WHO, a world free of TB with 0 deaths, disease and suffering due to tuberculosis, and to end the global tuberculosis epidemic. That was the goal. And certain indicators were put, and the milestones and the targets. 3 important indicators were put, that is the reducing the number of TB deaths in comparison to 2015 and reducing the incidence rate compared with the 2015, and TB affected families facing catastrophic cost due to TB. That's one of the important issues, as you all know. So when you reduce the number of TB deaths, obviously for the year 20, 25, 30 and 35, these are the goals we are put. It should be reduced by 35%, 75% and so on. For the TB incidence rate in comparison to 2015, it should be 20% reduction, 50%, 80% and 90%. Similarly, at all times, the TB affected families, they should not face any catastrophic cost due to TB directly or indirectly. It should be zero, it should be all free. So it should be every patient family should be accessed. So these are the, the targets of the NTB strategy, and they were based on 3 pillars and then few steps. If I see in the next slide, the 3 pillars were the integrated patient-centered care and prevention with early diagnosis and including universal drug susceptibility testing, and we'll see that gradually. Then with the bold policies and supportive system and intensified research and innovation. So these were the main pillars, and then certain steps. You see this, if you see okay, it is all right, we put up a strategy, but here, on the 2 bases, if you see what are the annual decline of incidence, you see, and the current global trend, you see the decline rate is only 1.5% per year. So that means again, the curve is not coming down. So if we optimize the use of current and new tools emerging from pipeline, pursue universal health coverage and social protection, then we can push or we can bend the curve, right? What we call, we bend the curve or push the curve, and then it is proposed that by 2025, if the reduction should be from 1 to 2% to about 10%, and then by introducing new tools like a vaccine is to be available, new drugs and treatment regimens for treating active TB and latent TB infection, and a point of care test. Then obviously, then further, even if we do that, we have to still push it further. If one has to reach the 2035, it should be reduction should be around 17%. Remember, so, simultaneously in 2018, 26 September 2018, the United Nations, that is the high level meeting for TB, that is called UNHLT. So they met, and then they made certain commitment that includes India. These are political commitments made. So this is what called the 90-90-90 strategy. That means we should reach at least 90% of all people with TB and place all of them an appropriate therapy, first line, second line, and preventive therapy as required. Then as part of this approach, we must reach at least 90% of the key population, which are the most vulnerable, underserved, at-risk population, and achieve at least 90% treatment success rates for all people diagnosed with TB through affordable treatment services, adherence to complete and correct treatment, and social support. Then our Honorable Prime Minister on 13th March 2018, he declared this was a landmark event towards complete elimination of TB from the country. Shri Modi ji announced that the targets for ending TB by 2025, because he advanced, he gave the target that it should be advanced by 5 years, much ahead of the SDG targets of 2030, emphasizing the importance of working together for the cause of the disease that is linked to the betterment of the lives of the poor. And then, but the point, even while the NTB strategy was announced or was thought of by the WHO, NTB strategy, United Nations, etc., I think certain challenges were also recognized. That is the persisting burden. I'll see that, we'll see that. Then stagnating the case notification. Even if you do something, they have to be notified through a system. The issue of the drug resistance, the HIV-associated tuberculosis, the non-communicable diseases and tuberculosis comorbidities like, the diabetes, then the smoking, Then the TB treatment outcomes. What is the outcome? That means the appropriate and effective treatment regime. And then the healthcare system. Obviously, we know that the healthcare systems are not very effective, through which this program is to be delivered. Then slow decline in the incidence, as I showed you in the previous slide. Then the funding gaps. It needs huge funding. We need money for that. And then the underlying determinants. Many of the determinants, as you know, the nutrition, housing, overcrowding, slums, so many things which are the occupation, many things. We all know use of, many immunosuppressive drugs. Of course, HIV is there. And then came this one, the last one, which came in, the unforeseen calamities, the COVID-19 pandemic, the natural calamities, etc. Suppose then we have to have the plan. The natural calamities occur, floods occur, landslides occur, earthquakes occur, many things occur. So how to handle? So these are the challenges that they were also recognized at that time. We can see just what is happening now. Again, I'll come back to you to the Global TB Report 2020. That showed, I had already said that about 1.4 million cases. So it is 1.2 million TB deaths among HIV negative people in 2019. It is a reduction from 1.7 million in 2000, and an additional, 2 lakh deaths, that is among HIV positive people. So it comes about 1.4 million. So 1.4 million, that there is a reduction. However, as I have shown you, if you remember, that should be, it is not fast enough to reach the 2020 milestone of a 35% reduction between 2015 and 2020. The cumulative reduction between 2015 and 19 was 14%, less than halfway towards the milestone. Similarly, the new cases, you see, it is around 10 million or 9.96 million. The decline was only 9%. Again, number of deaths, there is only 11% decline. And then number of resistance or the MDR TB cases, it is still they are fall below the milestones needed for NTB strategy. Right. So now coming to India, it is, I'm just quoting you 2019 figure, because 2020 was a different issue. We had the COVID, that will come little later. You can see in 2019, we had about 26.4 lakhs incident cases. They are notified to the system. The decline is only 2%. The estimated people who developed TB, and among them, about 333,000 were children. And then you can see the missing people with TB. This was the estimated, but about 18% the missing people with TB and who are not reported or could not be reported to the TB. We could not catch them. Then of them, obviously, there are about 287,000 were children. Then again, the drug-resistant TB, about 124,000 or 1,24,000 cases. So it is only a decline of only about 5%. Again, half of the cases were missed, because actual report was 67.431. These were the estimated cases. So the only it is 54.5%. Similarly, estimated people who developed TB and HIV. And then you see the death in India in 2019, it is 4.4 lakhs deaths. It is the decline is only 2%. And the TB is the number 3 cause of death among communicable, maternal, neonatal, and nutritional need. And still it continues to be a serious problem. And in 2019, you can see the total new and relapse cases, 21.6 lakhs. How many of them were tested with a rapid diagnostic test? It's around 17%. To know their HIV status, about 80%. So it is nothing, you can see none of the figures here. You can see which is reaching towards 100%. So again, you can see the rates per 100,000. It is still not there. It should be around 85. Again, it is much below. So this is, of course, the epidemiological, just to see the sex or the gender inequality. You see the females, although the age distribution is the similar, but you can see the number of females is still less in comparison to males. Again, if you see, this is the TB at different ages starting from 2010 to 2019. There is a decline, no doubt, there is a decline, but the decline is quite slow. And the same thing, you can see the people putting on treatment on different years. Even if they are notified, not everybody could be put on treatment. And then successful treatment, as we know, treatment is not always 100% success. So there is again still a gap. So this one again, that shows that again shows the TB, HIV co-infection, and then these are the drug-resistant TB. There is a decline, but it is not very much. Similarly, these are the patients who are put on treatment. Not everybody could be put on treatment. And then successful treatment story is, you can see this red and this blue is a very huge gap. Then these are the people with TB missing, I have told, although the missing TB cases are coming down gradually, but the point is still, you can see even in 2019, this figure is for 19, you can see still there is a huge number of TB, nearly 4.4 lakh cases of TB, they are missed, they do not come to the system. So this is, so therefore progress related to the global plan targets, which we are 82% people with TB, they reach at least, but we have to reach at least 90%, and then 82% who are diagnosed with TB. So there is still, so NTB by 2025, when we are discussing, we have to also know, everything is not bad. So we have to see what the program have achieved or is doing. So let us see an update of the program. Since the inception of the RNTCP in March 2006, I told you the pre-diagnosis and treatment are provided. More than 20 million TB patients are treated under the program. Remember, these are the figures for 2019. And more than 3.5 million additional lives have been saved. 1.4 million TB patients were tested for drug resistance. And 0.14 million drug-resistant TB patients are diagnosed. And more than 0.7 million TB patients that are notified from the private sector. That is one important thing. And remember, I had talked to you about the MDG, or the Millennium Development Goal. In fact, the TB epidemic in India, you can see the incidence has come down. Similarly, the prevalence, there is a 50% drop in the prevalence. There is a 50% drop in the TB mortality when you compare between 90 and that, as I had shown you. Again, but remember, there is a huge burden of deaths and suffering remains in India. Estimated 20 lakh incident TB cases in 2014 with 2.2 lakh deaths. And then again, the incidence is gradually coming down. The mortality is also coming down, but it is still not the target level. So therefore, a national strategic plan was developed for the NSP, that is called between 2017-2025, to have a vision of a TB-free India with the goal of universal access, and then with certain objectives: early and improved diagnosis, access to high quality treatment, scaling up access to effective drug-resistant TB treatment, decreasing the morbidity and mortality in HIV TB, and extending the RNTCP services to patients in the private sector. So from India TB program is caring for 1.5 million TB cases in 2016, and this has to increase to about 3.5 million should be cared for, and this will accelerate towards a TB-free India. And again, just to boost the everybody, the name was changed, the RNTCP, to National Tuberculosis Elimination Program from RNTCP. Now it is called the NTEP. That was the name was changed from 1st January 2020. And this is how it works from the starting from the ministries, CTD, states, districts, TB units, TB testing centers, district hospitals, block level health wellness centers. So this is how we have got a very well structured plan for that. And the dimensions of TB control from purely as a clinical issue, just diagnosing and treating, now to more dimensions added, that is public health and the social issues, where there is a patient support, engaging all healthcare providers, prevention, then the community empowerment, multi-sectoral approach, addressing the non-health determinants of TB, etc. So if you see the India TB report 2021 that was released in March this year, you see, but still, that gives a nice comparison between 2015 and 19. You can, these blue bars, these are the WHO estimated, because that number of cases should be there in India. But actually we are detecting what earlier we were telling, that a missing 1 million cases were missing. But gradually I think we are going this red one that shows the number of case detection is increasing. And these are the total case notification, both from the public and the private sector. You can see from the private sector, the things are coming up from the about 21% to 25, 28 from different years. It is not only coming from the public sector. So the private sector is also contributing. So 2020 is a different story that will, because that is the COVID era. So we'll discuss that at the end. And again, similarly, the case notification in 2020, you can see in 19, it was almost going very smoothly, but obviously came COVID, and you can see from April onwards, actually from not April, even from March onwards, then we had a dip in the case notification for 2020. And this is the same thing, the number drastically dropped. Then we have got the proportion of, over the years, the proportion of patients, they know they are HIV testing. These TB patients are tested for their HIV status. Then the TB notification, patient tested for universal DST or the molecular testing to know the resistance, rifampicin resistance. Now from 29% 2018 to about 67% in 2020. The success rate of the treatment from 66%. Now we have come up to 82% in 2020 and 2019. And then the TPT or the prophylaxis treatment for children below 6 years, it was mere 3% in 2018, but it has gone up to now 20 and 35 in 19 and 2020. So you can see the strategy of case detection, which is a very, very important parameter for the NTB strategy. In the earlier days, it was passive case finding based on the footfall in the health facility. And then we went on the intensified case finding, where the comorbid conditions like HIV, DM, or diabetes mellitus were also targeted. And then the active case finding started from 2017 onwards, where there was a systematic screening of vulnerable population like migrants, slums, prisons, contacts of DRTB patients, pediatrics patients. And then came the population-based screening from 2020 onwards, like vulnerable mapping, periodic screening of the vulnerable, etc. So this is how the target is to increase the case detection. You can see, say for example, in the how many people were treated in 2019. You see, these are the treatment in still, even if the figure seems very, because I should say it is happening once you are even, notifying the case, but the initiation is not 100%. The same time, the outcome assignment is not there because it is a longer time. So it is not always ends with December 19 or December 20. But again, you please note here, the treatment success rate was 82% only. So this is again not a very good thing. We have to achieve it should be 90%, and then 4% die, lost to follow up, even if it is 4 to 5%. I think these are not acceptable figures. And then these are how the active case finding you see at various hill states. These are just some of the representations how it is active case finding is done from door to door, reaching to the patient site. And also another important thing that was again came out that the number of TB cases attributable to 5 important risk factors, that is undernourishment, smoking, HIV, diabetes, and alcohol use disorders. So these are, so accordingly these are a very highly vulnerable group. So that is again another thing it was known. So then there was increased access to various diagnostics, like you can see the microscopy centers gradually increased from 14,000 to about more than 20,000 in 2019. Again, rapid molecular testing, again you can see the machines which was done, it is from 1,000 in 2017 to about 1530, and now a figure is more than 3000. And these are the biosafety level 3 laboratories, CBNAT, TrueNAT, and the LED microscopes, etc. So you can see these are the hierarchy of diagnostic network. We start with the microscopy center. You see the figure here is nearly 22,000. And these are with nucleic acid amplification test machines. I was telling, available to the program is more than 3,100. And culture and DST laboratories 47. Then the intermediate reference laboratory is 34 and national level reference laboratories. So there is a great, increase. But the point is, are they sufficient? That is what is the point. It is no doubt, yes, we have made good progress, but question is, are they sufficient? Okay. So this only just figures that shows how the line probe assays, first line, second line done, liquid culture, how many were done. These are only reports, but I think these are quite impressive. But again, I'll emphasize telling that, are they sufficient? So we made the progress. There is a pan-country rollout of injection-free regimen of fixed drug combinations for the drug-sensitive TB, access to free drugs to the private sector for the drug sensitivity TB as well as drug-resistant TB, decentralizing the molecular testing, then the DRTB treatment through the 173 nodal DRTB centers and 620 district DRTB centers. These DRTB drug-resistant TB centers are now established in larger institutes and at the district level. More, and then these are some of the other achievements done by this. And then we have got now addressing the comorbidity like the smoking, diabetes, and the HIV, of course, is there. And this is how this is from the NCD clinics, the non-communicable disease clinic. About 13% to 15% of cases are diagnosed from there. I think nutrition is one of the important things. The risk of TB increases by about 14%. So this is the risk of recurrence is 4 times those who are undernourished, and only about 1/3 of men and 1/4 of women had normal range BMI after successful TB treatment. So if you give them nutritional support, so these are the findings and well known. So I think for that the program is doing. There is a nutritional care and support for patients with TB in India. So then in TB and pregnancy, that is again another area. Then the pediatric TB, as I was telling, it was very, it is not very well, that attention is not given. Only almost 50% of our pediatric TB cases are missed. And therefore, again, the pediatric drug-resistant TB, the data is not enough. We don't have any official data, but it is presumed that there will be drug-resistant TB cases also. So obviously, to enhance that, we have got, the pediatric centers of excellence. I think one is at Calcutta, at the IPGMR, that is SSKM, that is Institute of Postgraduate Medical Education and Research, Calcutta. And therefore, the approach is now to detect, to find a TB case with an emphasis on reaching every TB patient, and treat that case with high quality anti-TB drugs, prevent the emergence of TB in a susceptible population, and stop the catastrophic expenditure, build and strengthen the supportive systems, including enabling policies, empowered institutions, and human resources, etc. So now the idea is to reach the private sector. And you can see there is incentives given to them. It is mandatory notification now. You all know that the laboratories, private practitioners, hospitals, chemists, anybody, any doctor. And then there is a public health action by health staff. So, this is, if you don't notify, it is punishable under law, including FIRs and fines. And again, the treatment service expansion, addressing the priority population and the patient support services. The treatment is now, it is a daily regimen since 2014. DST guided treatment again is there because every patient is supposed to get a, the CB0 for knowing his rifampicin resistance pattern. We have got Sutter regimen and newer drugs, patient-centric care, and reducing the out-of-pocket like financial incentives, and a direct benefit transfer. So these are the weight band based treatment. We have got now 5 weight bands, and then the fixed drug combination is given depending upon the what weight. So that has become more logical. Similarly, for pediatric patients, we have got 6 weight bands. It is again given based on that. Then for the adherence to support, it is no more done only by the humans. It is done through the, through the ICT or the IT based by what we call the 99 dots. And then there are many other things. The patient opens up one tablet, and then after two, then a number pops up, and then he gives a toll free. It means that he has taken the, the tablet. So this is how the things have changed. And then the direct benefit transfer, I told, it is given to the patient. Then honorarium to the treatment supporter. For the nutritional support to a TB patient, rupees 500 per month is given. And again, also incentive to private provider is given. Then the strategy is to build a urban TB control, health system strengthening, advocacy, communication, social mobilization, and then surveillance and monitoring. We have a NICHA, which is IT-based notification system is there. So everything is through the computerization. We have got now the TB forums at the national level, at the district level, and also at the society level. Similarly, the financing, as you can see, this is very important. And then you can see over the years, the most of the time it is the domestic financing, and we are depending less on the international funding. And these are the various through the NICHA. I told you all these financial things are also monitored. We have got national TB call centers that works around the clock to give the answer at the queries of the patients. Then preventing, we have got 4 or 5 strategies like the airborne infection control measures, particularly in medical colleges and other high concentration areas. Then strengthening the contact investigation, and then the prophylactic treatment. I showed you in high risk groups and children, the latent TB infection, and then addressing the determinants of the disease. So we have got a strategy where it is the engaging the private sector, active case finding, TB comorbidities, multi-sectoral response, drug-resistant TB, the tools for adherence and monitoring, various preventive measures. So these are the important components of the TB elimination strategies. Obviously, we have to know that TB is a social disease. There is a vicious circle of TB, poverty, malnutrition. It goes on and on. So I think this is one important area. So we have to redefine the multi-sectoral approach. And then now coming to just a few more slides about the drug-resistant TB or the MDR TB. Again, you can see India harbors about 27%, the largest chunk of MDR TB of the world. Again, we are the highest one, then China, Russian Federation. So earlier we used to compete with China, but now I think we have much surpassed, and the China has done a good job as far as MDR TB is concerned. And we have got data about periodic drug resistance surveys for MDR TB. So starting from 2000, I think the national MDR, the drug resistant TB survey, that shows that about 2.8% of our new TB cases are MDR TB, MDR or the rifampicin resistant TB, and the previously treated TB cases, the figure is around 11.6%. So we have got now data. So that is, I think, very important step and important knowledge. And then we had got a DOTS plus the standard one which are used. The problem was we are using it for 24 to 27 months with injectables and very toxic drug side effects. Right. Similarly, for the XTR TB, we had a regimen of similar duration, but here you are using the capreomycin and other drugs again for a period of 27 to 30 months. But again, unfortunately, even if with that till about 2017, when starting from 2007, the success rate for MDR TB was very, very poor. It was less than 50%, with about 1/5 of the persons they dying while treatment, and again another 19 to 20% of the patient they are lost to follow up. So these are the issues. You all know about the MDR TB patients, but for the XTR TB, the situation was still worse. It is hardly 1/3 of the patients were being successfully treated, and most of them were dying, around 40 to 50%, and another 15 to 20% they are lost to follow up. So these are very, very, very hopeless situation. Let me put it that way. So then obviously the new guidelines came up with the advent of newer drugs. So these are the updates came, and then the WHO grouped the drugs It is now called as group A, B, C, depending upon their efficacy and the safety profile. So group A drugs will be the fluoroquinolones, bedaquiline, linezolid. Group B will be clofazimine, cycloserine, and then the other drugs are put in the group C. So the idea here was to, for a regime, all the three medicines from the group A and add one or both medicines from the group B has to be or have to be added, and then to complete the regimen, and when medicines from A or B cannot be used, then group C drugs can be chosen to complete the regimen. Again, another new definition obviously came in for the XTR TB in particular. You know, the definition has changed now. That will be that is applicable from 1st January 2021. That means it is a MDR or RRTB that are also resistant to any fluoroquinolone, and at least one additional group A drug, either bedaquiline or linezolid. You know, they are group A drugs or both, either one or both. Earlier it was second line injectables, but I will see, as you will see subsequently, the injectables are no more being used for various reasons, right? So therefore, the here again from the pre-XTR also, the injectable resistance part is taken up. So we have got now the guideline for the drug resistant TB in India. Their problem of drug resistant TB is the underdiagnosis, the treatment, long duration, toxicity, efficacy, which I showed you. There is a complexity in management because adherence, injectables, adverse drug reaction, severity of disease, etc. Now we have got a definite diagnostic and treatment algorithm. And then you can see, the only thing you see, although this figure, this graph looks very impressive, but again you see, if you year-wise, these are the DRTB suspects. So what we did, 66,000 cases in 2019. Of course, 20 figure is not yet complete. Again, but we could diagnose only 56,000 cases. The problem is here, but you remember, if you remember, I had told you we had got an estimated 1.24 lakhs of cases of MDR-TB, meaning thereby even in 2019, we are diagnosing only 56,000 cases, almost around 54%, which I had shown you. So that is a big disadvantage. Number two, the putting on treatment, not everybody was also put on treatment, although we have got now increased our lab capacity, etc. So this is although one can say, oh, this is a big number, we have diagnosed 3,52,000, it is the way how you put the statistics, right? And then we had got the now new drugs. So obviously, pretonamide, bedaquiline, delamanide, these are the new drugs, they have come now. So then the treatment regimens have been changed by WHO, and fortunately India has also adopted those things. So we have got the treatment that is all the INH monoresistance, which is a issue because the success rate is very poor. Very soon they go into the MDR-TB. So we have got the PMDT Indian guidelines. So you know the INH resistance. If you do the LPA, so and then you know the INH resistance. So it is 6 months rifampicin, INH, pyrazinamide, and levofloxacin replaces INH. So again, you see it is not recommended to add injection streptomycin or other injectable agents. Of course, it can be increased to 9 months if you feel in certain circumstances. So till May 2020, nearly 22,000 patients have received the treatment. Then came the Sutter MDR-TB regimen. If you remember, I have shown you the earlier one. It was 27 to 30 months. This came following the short, highly successful regimen, so-called Bangladesh regimen. So then it was tested in various countries, including Africa. You can see the success rate was as high as 81.6%. And this has impacted very intensely. The Sutter regimen success has gone up to, you can say, from 84 to 89%. So therefore, this regimen again consists of 9 to 11 months therapy. The only disadvantage with this was the kanamycin injectable has to be given in the intensive phase. Of course, the total duration is 9 to 11 months. However, the possible reason for Sutter MDR-TB regimen is to be effective. And then again, you can see huge number with this regimen we are treated for that. And you can see a treatment success rate. Even in the program, it is 68%. If you remember earlier, it was less than 50%. Again, so we have, there is a treatment outcome of MDR treatment that has gone up to about 68, 67, 69% at different quarter. These are quarterly reports, right? So therefore, when bedaquiline became available, the only problem was the previous regimen. There was a kanamycin injection. We wanted to avoid injection. So here it is a all oral short course regimen, 9 to 11 months. Here bedaquiline is given for 6 months with the levofloxacin, clofazimine, pyrazinamide, ethambutol, and high dose INH and ethionamide. And then after 4 months or 6 months for bedaquiline, then these things are taken off. High dose INH and ethionamide are taken up, and these 4 drugs, so is a complete duration of 9 to 11 months. So therefore there are certain recommendations. So we prefer where certain regimens. Then came the all oral longer MDR-TB regimen. Here you can see as the this is the regimen. It is 18 to 20 months. That is bedaquiline for 6 months, levofloxacin, linezolid, clofazimine, and cycloserine. These are 5 drugs. Bedaquiline is stopped after 6 months because it should not be given beyond 6 months. So this is the all oral longer as well as shorter regimen, and the experience from the CAP, the conditional access program result, you can see 83% sputum conversion within 6 months, and the medium time to culture conversion 60 days. And then it is of course, it has got certain side effect, but one has to be careful. So what we have moved towards a injection-free treatment regime. Previously treated INH mono or polyresistance and MDR or rifampicin resistant TB regimen. We have moved from there. So, and there is a new regimen again coming that is called BPAL, bedaquiline, pretramadinib, linezolid. The program is doing a trial to see at the field. So this is not yet recommended for the program, but this is under so if I summarize for you, you see what was happening. These are the earlier ones. So it was less than 50% in different years. And then when we use similarly for the MDR and XTR TB patients, but now with the use of these newer regimen, shorter or longer, you can see how the things have changed and improved that I have already told you. So all these things have come up that I have already discussed: shorter MDR-TB regimen, bedaquiline containing regimen, delamanid containing regimen, and all oral longer regimen. So therefore, our strategy is to prevent, detect, treat, and build a system where one can treat. We all know these are the achievements, these are the how to prevent it. As regards the prophylaxis, there are how it is to be done. We have got isonized preventive therapy. Now newer things are coming up, 3 months, rifampicin INH regimen, and then there are new drug regimen for MDR-TB contacts also. They are coming. What is happening? The gazette notification, I have already told you, all medical colleges are bound now to have a DR-TB center in their medical college. Otherwise, it cannot be given. So they now come to I have told you all the positive aspect. Now I think let us come another 5 slides. Can I take up Dr. Ganguly sir? Yeah. So you see the burden of TB in India. You see the recent authentic incidents and prevalence. We have got a huge risk factor. India was called as the diabetes capital. We have got over 72 million cases in 2017, and by 2030 it is expected that about 98 million adults will have TB. Then we have 2.8 million live with HIV. We have huge number of immunosuppressive diseases and drugs. We have got cancer burden, organ transplantation, but these are the determinants of TB. Right? Then malnutrition, you see 20% of the population, the children, they are wasted, and 6% were severely wasted. Low BMI is present in nearly 1 in 5 Indian adults. 10 million are at risk for silicosis as regards occupation, overcrowding, slums, prisons, shelter homes. We have got 134 central jails with the 1,59,000 prisoners. They are overcrowded. Actually, the occupancy rate average is more than 100%. Urban Indians living in slums, about 24%. That is about 100 million people. Over 9 million, that is 60% of the population of Mumbai, 18.7% in Delhi, 10% Bangalore, 5% in Calcutta, 15% Hyderabad. They are living in the slums. And healthcare workers, so these are the vulnerable group who are likely to flare up. Remember, that is one issue. Then the latent TB infection. We know 1/3 of the world population is having LTBI. India, it is around 50%. So meaning thereby it will be around 40 to 50 crores. The other issue is it may not be health is in concurrent list. I'll tell you, I'll show you subsequent slide why I have put this health is in concurrent list. Then the center state coordination is very, very important. And the TB control program, it is delivered through state health service. And there is a system called 60-40 finance ratio. For the program, 60% is contributed by center, 40 by state. It is many people do not know that. Then contribution and management through the state, the NRHM system, it passes through bureaucracy. So I do not like to comment any further. And of course, the issue of human resources. Then, one of the, I always, I am take very strong exception to that about, we are fighting a disease without knowing what is the burden. We are fighting an enemy without knowing its strength, right? We have the first national survey done way back in 55, 58, you remember the ICMR survey, Professor Ganguly must be knowing it. So, at that time it was done, then subsequently you calculate how many years now, it is 70 years. Of course, there are sub-population studies at different places that shows, and then what it shows, I'm not going to bore you with the slide, that shows these sub-national studies that shows the bacteriologically positive cases per 100,000 population varies from 170. There's a very wide variation, both in the bacteriological either incidence or prevalence. So then therefore it says there is a diversity in TB burden in different parts of the country. There is no clear correlation between prevalence and notification or treatment success rates. There is a mix of efficiency of TB control interventions, living conditions, and local cultural factors. Then again, you see the tribal population, you see the huge difference in the, you see the national figure is 193, but you see on an average, it is about 703. It is particularly the Saharia tribe, which is mainly concentrated in Madhya Pradesh. And you can see this is the population vulnerability. This is another issue. So fortunately, we have a new TB prevalence study that is ongoing between 2019 and 21. It will cover 500,000. It will be one of the largest exercises here in the world. And then here the vans, the mobile vans will serve as a fully equipped mobile clinics. CBNAT will be used. And then this will generate a new knowledge. I hope that will be helpful. However, it is a challenging task due to the size and the complexity, we all know. And again, you see, I think another important factor I like to draw your kind attention, it is the use of or the sale of TB drugs in the private sector. It is data is given from 2013 to 2016. This is a publication in 2019. You can see still, these are the millions, in millions patient months of TB treatment still, although it is coming down, but still in 2016, it is more than 16 million in the private sector. In the public sector, of course, it is steady. And these are the 5 states, that UP, Maharashtra, Bihar, Rajasthan, and Delhi. So what it again says that our focus should be more on these things. And this is again about the TB burden, TB prevalence, depending the wealth quarantine. I think that is very well known that I have already shown you. So there is a aim is to end the poverty, to end TB. So the social protective measures are very, very important. And then the Nikhya thing I told you, you see the public, how do we deliver the public health care in this country? We have got, again, very funny, we have got different type of health care delivery system. We have got primary health cares, where we have got PSCs, sub-centers, we have got hospitals, health centers, CHCs, rural hospital, district hospital, specialist hospital, teaching hospitals, and then health insurance schemes, And we have got other agencies like defense, railway, etc. So there is a varying health care delivery system. That is again another issue that is taken into account. You know, the private sector itself, it is not also uniform. We have got private hospitals, polyclinics, nursing homes, dispensaries, general practitioners, clinics. We have got indigenous system of medicine, which is being, you know, is encouraged, and these are actually official. We have got Ayurveda, Siddha, Unani, TB, homeopathy, voluntary health agencies, national health programs, so on and so forth. So, you know, you see why the private, you know, again in 2010 publication, you see, this is a study from Bombay that you see only 6 of the 106 respondents wrote a prescription with a correct drug regimen. Remember, that is a very, very sorry state of affairs in this country. Then the functioning of CTD and the TB cells, whether it is center or in the state, is there the manpower is adequate? The field staff, contractual manpower, procurement issues, drug chain management, administrative issues, pharmacies. So by and large, sincere effort is being made, has brought out significant improvement and achievement, but still there are issues. Again, you see, these are the case notification. You see, this is just, it is not, I have just specifically took out to certain states. You see, you can see these things in red, you can see these are gap in achievement in the notification rates. Many states still they have got a gap. And similarly, if you see, these are the missing TB cases. I have told you out of 100, they reached the diagnostic center 67, diagnosed with TB 59, registered for treatment 53. The graph goes down and down. Ultimately, recurrence-free survival, this is somebody has made a modeling study, of course. This is a modeling study. So this is again the number of not initiated on treatment. I was telling you, still in many states, you can see, including, I don't want to name any state because this is a uniform thing. I have only presented few states just to tell you. Now coming to the funding has increased to 4 folds. For different areas, then still we have got a huge gap of the fund requirement, although it is mostly by domestic funding, but the one in the blank is still there is a huge gap in the funding. But again, I think please have attention to this slide. You see, fund is available. The question is a utility. You see, Bihar, Gujarat, Madhya Pradesh, Maharashtra, Rajasthan, and Uttar Pradesh. You see, this is the total budget is given, whatever it is. But then actual expenditure, you see, that is in orange. You see you see the gap. What is the gap? Except I think Gujarat, where it is almost 95% utilization. But the most of the states, it is only just a representation to show that even allocated budget is not spent. Whose fault it is? So Financial Management Report 2018-19 says average national utilization of the allocated funds under them was only 49%. So there are state governments face some key challenges regarding financial allocation and utilization, prioritizing TB and allocating funds in proportion to TB burden, matching the resource, low absorptive capacity, then timely dispersal, release of allocation funds. Again, you can see the expenditure from different zones. You can see it varies from 63 to 192 at different years. Nowhere it is, some states of course do very well, but they are very few. So there is a huge gap. Again, you can see the HR, the human resource, whatever is sanctioned, you can see they are in position 39%, 55%, 67%, 18%, some states. So these are the deficiencies. Of course, there are many other issues, but I'll just like to tell you about the medical education policy. Teaching in TB, it is a very pathetic and unfortunate thing. The most of our pulmonologists are now towards the non-TB area, the teaching in TB having a problem. Our curriculum is having a problem. So this is just a recent publication. This is the case fatality ratio. This is done at the private sector. This is a study done at Patna. Again, you see the case fatality rate was 7.27%. Actually, as for if we achieve the NTB strategy, it should be less than 5%. Right? So it is still 7.27%. And the less than 1 month of treatment adherence. If you don't follow them up, if you just prescribe, then you see about 32% of the people will have, 32% if you follow them, and if you don't follow them, 13.5%. Similarly, there are certain recommendations. I think we have already discussed that. So I will not go to those details. So therefore, we had got another issue while all these things are happening. This pandemic came in. You can see this is the TB notification came down heavily. States like Bihar, 51%, Manipur, 52%, Uttar Pradesh, 50%, West Bengal, about 2%. So these are the different states and union territories. Again, you can see the total case. If you see the right-hand side extreme end, we have got about 60% less case notification in 2020. And again, this is the Acharya data that shows the case notification rate only was 60% of our target, and we only achieved 60% case notification, that is 51% from the private and 65% for the public sector. They are the expected. So if you see what happens, the recent data that is released by Stop TB Partnership on 18th March 2021 that says there will be an additional 6.3 million cases of TB and additional 1.4 million TB deaths. Both global TB incidents and deaths in 21 will be increased to the levels last seen in between 2013 and 2016 respectively. So this is a setback for at least 5 to 8 years in the fight against TB due to the COVID pandemic. This is again, you can see India, if there is a lockdown and there is a recovery at different months, you can see the TB number will be increased to that much. So therefore, including India, these 89 different countries, the TB diagnosis and enrollment and treatment will be declined to a larger extent. So, ladies and gentlemen, I'll just summarize what I said. An overall of the business as usual approach to TB need to be is required, and a paradigm shift. Our attitude, whether we are working in the private sector, government sector, whether he's a bureaucrat, he's a politician, he's anybody. So business as usual, chalta hai attitude has to be changed. Then more determined push to accelerate the scale of TB care and prevention, increase the investments in the research and development of new tools so that no one is left behind. Plan is centered on strong political leadership to achieve the country's shares of the global TB targets agreed in the UN political declaration. It highlights the need for a rights-based, people-centered approach, accelerate innovation in care delivery, the introduction of new tools, substantial investment, and research and development, and a strong country response. So my take is, it seems to be a difficult task, but it is achievable, but coordinated effort and hard work. And then we must forgo chalta hai attitude and may have to change and redate the NTB strategy. This hard task is ahead for all of us and for the program, for the government. We need a good public health response. Actually, I should say, science does not fail us. We are responsible to fail ourselves as well as science. So thank you very much, your kind attention, but I am still hopeful, TB harega, desh jitega. So TB will be defeated and the country will win. Thank you very much. Jai Hind.
Thank you, sir, for such wonderful wrapping of a very complex and multifaceted problem of TB, multi-drug resistant tuberculosis, and all the contributing factors leading to the present situation, and ending it with the good hope. So without going into it again, we are now moving to the next session. This is regarding the Acharya Prafulla Chandra Roy Memorial Innovation Award. And before we name the awardee, may I request Dr. Dhiman Ganguly to say a few words about Acharya Prafulla Chandra Roy. Dr. Ganguly, sir, please.
Thank you, Partho Sarathi. Am I audible, Partho?
Yes, yes, sir.
Okay. Well, it's really wonderful that Institute of PulmoCare has started this oration quite a long time ago. I think this is the 12th Acharya Prafulla Chandra Rai Memorial Award. Acharya Prafulla Chandra Rai is considered to be the father of chemical sciences in India. He was born in 1861, 3 months younger to Rabindranath Tagore. They were born in the same year. 19th century Bengal is a wonder for all the sociologists all over the world. How could so much of talent be born in a small geographical area in such a short space of time? Acharya Prafulla Chandra Roy won a Gilchrist Prize, which was quite a tough competition in those days, and went to Edinburgh to complete his education. He came back with a PhD in chemistry, joined Presidency College of Kolkata in the chemistry department. But to describe him as a great teacher is only giving him a partial introduction. He was a philanthropist, an industrialist, started Bengal Chemical way back in 1892 when hardly anybody thought about Indian industry. He never married, led a monk's life really, left Presidency College and joined Science College at Rajabajar when Sir Asutosh Mukherjee started the first science college in India, and spent the rest of his life till he died in 1944. He used to live in the same building on a small room in the first floor, and among his students there are so many that I can keep naming them for half an hour. To name a few: Professor Meghnad Shah, Professor Satyen Bose, Gyan Mukherjee, Gyan Ghosh. They are all products of Presidency College in those days, and Acharya Prafulla Chandra Rai was an inspiration for all of them. Acharya Prafulla Chandra Rai was the man responsible for introducing Mahatma Gandhi to Bengalis, because Gandhi came to Kolkata sometime around 1902, I think, to attend a Congress meeting, and Acharya Prafulla Chandra was responsible in introducing him to general public. He was a great supporter of Charkha as an Indian way of supporting poor people, and his philanthropy, knows no bound. So it's wonderful that we have a Acharya Prafulla Chandra Rai Memorial Award Oration in Institute of PULMOCON for the last 12 years. And I hand over the proceedings to Parthu Sarathy to introduce this year's speaker of PC Rai Memorial Award, Dr. Anurag Agrawal. Over to you, Parthu.
Thank you, sir. Now it's my pleasant duty to introduce Dr. Anurag Agrawal to the audience. Doctor, I was introduced to him around a decade ago in one of the NAPCONs, where the so-called who's who in Indian pulmonology were there in a small meeting. And I was really impressed with his depth of knowledge, his attitude towards the medical science and research. He graduated in 1994 from All India Institute of Medical Sciences. And as an exception, he actually chose a career of a researcher. He could have been anything, any subspecialty expert and famous in that field, but he is a different guy. He did his PhD from the Delhi University, and before that he went abroad to Houston to complete his training in pulmonary disease and critical care, and then returned to India. His primary area of interest is respiratory biology. And it is a good luck for us that such a brilliant man is taking his time for the development of respiratory medicine and respiratory research. His second interest, or I can say broader interest, is implementation of emerging technology in healthcare. This is very interesting. We have been interacting with him time and again. In between, we invited him to Kolkata for one lecture in one of our summer symposium. He was talking about impulse oscillatometry like a physicist. And I was wondering, a person who can have so much of grip on the technology area and next moment he can switch on to an area of molecular biology. This is something very exceptional and very, very praiseworthy. He has a lot of laurels. He co-chaired the Lancet and Financial Times. He is one of the members of the expert group of WHO. And as a scientist, what would I say? That he's been very successful. He has already been a recipient of the so-called Indian Nobel Prize, the Shanti Swarup Bhatnagar Award for Science in 2014, and he only recently received the Sun Pharma Research Award for Medical Sciences 2020. He is already a member of the Indian National Academy of Science and Indian Academy of Science. So with this brief introduction of Anurag Agrawal, I hope you are all interested to listen to him. Today he is going to talk about how to ignite innovation in young minds. And before that, I have got a pleasant duty to request Dr. Ganguly to confer the award to Dr. Anurag Agrawal.
Yeah, thank you, Partho. It's a great pleasure on my behalf to virtually present him with the Acharya Prafullo Chandra Rai Memorial Award Oration for the year 2021 in this year's PULMOCON. I wish I could have, I would be happier to do it physically, but that's not possible. Please accept this award from our behalf, and over to you, Partho, for his, over to you, Dr. Agrawal, for your talk.
Thank you so much, Professor Ganguly. It's an honor to receive this through you, and even more importantly, I think it shows the vision of Partho in the way he has put together two very renowned figures. One coming from medical primary discovery in the biomedical sciences, to an understanding that Professor Prafulla Roy was not only contributed in a innovation chemistry, but to show that innovation is the backbone of what this country needs today. He founded Bengal Chemicals. And it's an honor to be asked to speak about innovation in this context. I'm going to just quickly switch over to my screen. And I think you should be seeing my screen about now. So the topic I'll talk about today is igniting innovations in young minds. And I think that's a really, really important topic. Let me reduce this.
You are muted, Dr. Agrawal.
Oh, I'm sorry. I don't know how that happened. Can you hear me now?
Yeah.
Okay. So innovation in biomedicine is very much like normal innovation. You have to do something unique. You have to do something with impact. But it does not happen without a few things that we find are very difficult in the medical system. And I've trained here in India, been outside, come back, been a faculty, been a student, a culture of questioning, experimenting, accepting failures, and trying again. This is something that perhaps partly because as doctors, we can't afford to fail, or at least we feel that way. So we sometimes want to take a safe course, but without this culture of questioning, experimenting, it's very hard to innovate. The second important part is you have to have knowledge of and access to. Both words are important. The frontiers of biomedicine, that's where the biggest innovations are happening. If you look at the wonderful talk by Dr. Behera earlier regarding whether or not we will cure TB by 2025, one of the things that might stand out to you if you're listening to it from my viewpoint is look at how little innovation has happened in tuberculosis in terms of treatments, in terms of diagnostics, in terms of figuring out who's going to respond, not. And it is one of the biggest killers in this world, as Dr. Behera showed so wonderfully, one of the most important things. And yet, if you look at the amount of innovation that has happened, almost nothing. So if we are not going to have innovation in biomedicine, we will not achieve any of the things that we need to do. The two other things I will talk about, and these are personal experiences. I know that many people do not agree with me on this. The concept of a protected time for research and the concept of a career track for physician scientists versus academic clinicians. All of these things are equally important in pure research as well, but you don't need protected time because you're doing pure research all the time anyway. But career tracks are important there too. But one of the things that I saw always as a huge difference between what I saw in the US, where most of the innovations that we use in practice today come from the West. Almost all the physicians who are leading scientists do not see patients equal to other clinicians on a daily basis. Almost all of them have protected time that they can dedicate towards running labs, building research groups, and doing work. In fact, one of the first problems I faced when I came back was that it had to be a choice, right? It had to be a choice of joining a medical institute, sharing the same clinical burden as my colleagues and trying to do my research on weekends, versus joining a research institute, focusing nearly full-time on research and seeing what clinical activity could be continued side by side. And of course, there are examples within this country of people who have managed to perhaps do both. But if we want to increase and ignite innovation overall, we cannot only rely upon people who will do a full-time clinical job and then a full-time research job over the weekend. That's simply not how the country as a whole can move forward. And then the career track point, I'm going to state this right up, is very important. One must distinguish between physician scientists who are equally capable of being employed and sought after as faculty by medical as well as a research organization versus academic clinicians who also do research as part of their clinical practice. So, I see this figure very often. In fact, I made it once for a particular talk I was giving. Triggers of innovation in medical science. And triggers of innovation in medical science can be a clinical question leads to a clinical person wanting to go towards research. It could be basically an inefficiency of care, a suboptimal outcome. For example, we are seeing in tuberculosis. The reverse can occur in basic science research, where people have a biological question, curiosity, an opportunity to go further. They might come to the clinician to get some samples, to test some idea. And when you try to project it in a nice way, it goes beautifully round and round. You can call it bedside to bench, bench to bedside, and the full circle gets completed. My experience, in reality, it looks like this. It looks like this because there is so much uncertainty in medicine and biology. There is no simple round. I mean, you go off into all kinds of offshoots and directions, and then you pursue them. So many of them turn out to be wrong, false leads. You might come back exactly where you started, but you persevere on. And unless you persevere on, it simply doesn't work very well. And what I'm going to talk about in the beginning is to show you how difficult it is, but how possible it is. In 1997, my former boss, Professor Sameer Brahmachari, looked at how little was known about ataxia. It's a disease I know very little about, so please don't question me on it. There are so many types, familial, there are subtle clinical differences, so little was known about Indian spectrum. Everybody was sending their samples to foreign labs. People were making genetic discoveries, innovating regarding the understanding of ataxia on Indian samples because we were not able to do it ourselves. And this is a reality that you might hear of even today. In 1997, Professor Brahmachari, Professor Satish Chan at AIIMS decided to come together and bring together a top-end medical institute and a top-end research institute and work through training of people with medical backgrounds as PhD candidates, focusing on this topic to do not only what, is standard genetic testing that we could have done without 20 years of collaboration, but to also do primary discovery in the area of ataxia, to build immortalized cell lines from every one of those patients, create resources of the type that is necessary to build fundamental understanding in this area. About 20 people just on this one topic of ataxia probably did PhDs. At least 6 of them were people with a medical background. And I'm not going to spend a huge amount of time on it. But the result was that when there was a discovery of a new drug for ataxia in a particular form, and they wanted to test it in actual human cells, the US, for a change, was forced to come to India to look at immortalized cell lines from patients and do the research work in vitro in India. And both AIIMS and IGIB were very important parts of this very critical, well-known paper. And this is basically about synthetic transcription factors, and a lot of work more is happening since then. But basically, India became part of the global innovation circle. And even this was not fully satisfactory, because if you look at the original molecule, we had almost no part to play in the discovery of the molecule itself. Meanwhile, what we have done despite those limitations is that to have clear ideas that you must continuously innovate on a discovery platform, and you must convert those discovery platforms to delivery platforms for low-cost healthcare. If today you were to go to Lal Path Labs for a neurogenetic panel, you will find IGIB's name somewhere on their brochure. The reason is genetic mutations in India are very different from what's reported in Western literature. You can do whole genomes, whole exome sequencings to identify these mutations, then build affordable tests on the back end. And this completes one cycle of small innovation in which you go from very large scale genomic work to very affordable diagnostics that then you work with the private sector to make it available to the public. And we call this our Guardian program and GoMed program. I mean, the numbers are much greater than they are in the slides. Today, we have 100 plus clinical centers, probably 500 plus clinicians, and I mean, probably 20, 30,000 patients being tested every year, especially now that Lal Path Labs is carrying out some of this work. I'm going to come now briefly onto some of my own personal life lessons on what blocks and triggers innovation. My background was that my primary interest was computer science engineering. I joined AIIMS Delhi for MBBS with many other confused people. I did pursue higher training in medicine, pulmonary disease, and critical care at Behera College of Medicine, shifted from there to experimental research, shifted from there to data science and public health. And I'll give you a glimpse of some of the areas I believe are important for innovation. The first example I'll tell you is my first paper. And this paper was instructive to me in some ways. All of us as pulmonary people know that to measure thoracic gas volume, you make people pant against a closed shutter. I'm also an asthmatic. So I actually also suffer from the asthma, and sometimes when people want to measure my lung volume, I'm not feeling very well. And when I'm not feeling very well, and this was medical school days, you realize it is very easy for a normal person to pant, but not that easy and that comfortable for a person who's anyway short of breath to try to do this. And the funny thing was, how to measure specific airway resistance was already known. You can do this without panting. It's a product of these two, and the first equation you can see over here. Now, simple mathematical logic would tell you, if you make the measurement twice, but in the second measurement, you add an extra resistance, which you have to build a device for, and you make the two measurements, you subtract the first measurement from the second measurement and divide by the resistance that you yourself have added to the circuit, you can actually calculate the thoracic gas volume without ever having the patient pant against a shutter. And this is something that we quickly built a device for. And basically, there are two shutters now. If you close one of them, the person has to now breathe through a path of the additional airway resistance as well. This was my first experience with doing research. This project was actually very fast. It took about 6 months to complete. It was also possibly the only paper in my life that got accepted without a single comment during the review. The only comment I remember receiving was, "We wonder why nobody else has thought of it this way before." And at that point, you're a medical student, right? I mean, all you know is a little bit of algebra. You're taking an equation of what is known. You're adding a second equation. You're thinking through how to build a device, nothing weird about it. When the shutter is open, the air will flow this way. When the shutter is closed, the air will flow this way. Nobody has to pant against a closed shutter. Two measurements with an additional resistance. And this actually got taken up by the European Respiratory Society and a bunch of other things. But I also learned how ideas die. What I did after doing all this was apply for a patent and leave off for my residency. Nobody pursued it. Nobody actually built the device. So although it would have been theoretically very convenient, nobody would have to pant against a shutter. It was covered by the European societies and everybody else as an important innovation. The fact remained, innovation, unless you take it forward and convert it into products and bring them to market, they all go to an early graveyard. And if you truly want to ignite innovation, you have to build the ecosystem in which people actually convert science into products. I will not spend too much more about that. I mean, still the medical schools in India aren't doing any of this, but the IITs are. And very soon the IITs, like for example, IIT Kharagpur will have a medical school. Maybe we will see a mingling of these interfaces in these new engineering schools plus medical school combinations. But this is something that's very important, my own personal experience. But quick lessons. Even if something is very well known, I mean, measuring lung volume is done through multiple techniques. Every pulmonary physician probably would think that everything that is there to be discovered has already been discovered. I probably thought the same way, except I was not a pulmonary physician. I was a medical student finishing my internship. So I did not feel I knew anything. So because I did not know anything, there was scope to improve upon what exists. Large blind spots exist between the eyes of different scientific disciplines, and you have to train in a variety of ways or read a variety of things to be able to see these blind spots. One of the most important things I personally learned in my time in America, apart from medicine, pulmonary, and critical care, was I learned to ask more and better questions. I used to realize when people, very famous people, used to come and give a talk, even if I did not understand something they said, I was always trying to use my background knowledge to see how I could understand what they said, as opposed to challenging them and questioning them. Half of what you know in medicine is wrong, and you don't know which half. Go back to a textbook 20 years ago. People were equally convinced then they knew what it was. Look at how little of it you do today. So I always tell people, if you're going to do biomedicine research, half of what you know is false, you have no idea which half, please come to it with that approach. And learn to ask questions. If something doesn't make sense to you, speak up. Very important. I am wrong 2/3 of the time with every idea that I come up in my lab. And knowing that I'm wrong 2/3 of the time, I could be wrong 3/4 also, 2/3 is just a number, allows us to do better quality research. And I always worry about one thing. My students typically have to end up changing their PhD question, at least half of them, and yet I don't see that happen often enough. So that's the other thing that's a killer of igniting innovation. There is pressure upon people to find things along the lines of the original questions they are given. And I'm not going to say too much more about it. When you start coming to MD research in India, the problem is even more severe. MD and DM research, it is very troublesome. Good research, you have to be wrong often. If you're right with the thing that you thought out when you start to do research, you're either doing incremental research in which everybody knew what was going to come, or there is a problem with your data. And I'm being very blunt about it today. These are the things that when you train in research in this environment, it kills innovation, because you don't realize there are other people who actually answer questions genuinely and come up with innovative ideas and translate them. So that's what I learned during America. It's okay to be wrong. It's okay to ask questions. It can be a world expert in front of you. If something they're saying doesn't make sense, please ask. The other important thing I learned over there is, if you want to innovate, pick a decent research question with a future. And I'll just quickly take the example of what we picked. It could have failed, it could have worked. There is no guarantee anything is right. But at the time I came back to India, there were twin epidemics of obesity and asthma. Multiple studies had confirmed an obesity-related dose-dependent risk of asthma, bidirectional. And many people found that insulin resistance was a better risk index than adiposity. And many people were talking about how multiple lung diseases are being linked to metabolic disease. Now, at that point in time, nobody was even thinking of mitochondria and asthma. This is about 2003, 2004. You will not find a single paper for mitochondria and asthma at that point in time. But we figured, if there are two such important things coming together, maybe mitochondria are important. And they are very well known as effectors in metabolic disease. Nobody had done much work in lung disease. We could think of how metabolic products could affect them. And we actually had the first paper showing mitochondrial dysfunction in models of asthma and in biopsies in 2007 in Journal of Immunology. And from that point onwards, we pretty much in the beginning led the field. We dropped down, unfortunately, when it came to the clinical work, but we were amongst the first labs in the world to show how both metabolic and airway disease like asthma can be very nicely explained by things like methylarginines, metabolic stress, and a huge number of papers from our lab during that phase tried multiple things, mostly animal models. Most of these things that we showed in animal models, in fact, went on to undergo human trials. But again, we were not able at that point. I was early in my career, and not possibly today I would be able to get it done. But that time I was not. So you would find almost all the clinical trials for these things, ADMA. You type asthma and severe asthma. You look at ADMA as a marker of metabolic asthma. You look at L-arginine trials. There's a beautiful JCI paper just maybe a year ago. All of them originate from work done in India. So innovative biological work, I will not call it fully medical, but biomedical in a sense, animal models of disease, but failed to get to that last part about getting enough number of people interested in testing out these ideas in human trials. The other big discovery we made around time, and this was serendipity mostly, and my only credit is I didn't stop the PhD student from asking this question, which most people thought was impossible. What he was wondering was whether stem cells or fibroblasts can donate mitochondria to dying lung epithelial cells. And it turned out he was correct. And my only credit is I allowed him to experiment with this particular idea. You can see these nanotubes between cells. You can see mitochondria move. We proved this in living mice, where by giving MSCs, we could see transfer of MSC mitochondria into the lungs of mice. We could show very, very briefly, just remember one thing, that's an airway. Brown thing is remodeling. The fourth one, the one that I'm showing here, is a stem cell that we have engineered to give lots of mitochondria and anti-inflammatory compounds. Remodeling completely disappears. And the last one is an asthma model where we have killed the mitochondrial donation ability. It does not get better. Mitochondrial donation is absolutely critical in rescuing airway remodeling. 300-400 papers have cited this work of ours since then. Now it is being shown to be important in stroke. It's being shown to be important in heart attacks. It's being shown to be important in every possible things. But again, the sad part is none of the clinical trials are actually happening here. So while the original paper is from here, the clinical trials are happening mostly elsewhere. So we came out with a 3R model of targeting mitochondria, repair, replacement, reprogramming. I will not speak too much about it today. But one very important line of thought that is finally reaching clinical trials is that we predicted, based on in silico computational work that my lab also does, that bacteria make compounds that affect their cousins inside our cells called mitochondria. We were able to predict certain compounds coming out of the gut microbiome that, gut microbiome, metabolic health, people talk about a lot, but how gut microbiome could be making compounds that will influence respiratory health is new directions. I will simply point out two things. I was very pleased when in ATS 2018, mitochondrial dysfunction became one of the highlight topics of the meeting. And I was asked to create the session on how targeting mitochondria could lead to new prevention and treatment in respiratory disease. As you know, it is hard to create, chair, and create an entire theme in ATS. So I was very happy that happened. And meanwhile, we were able to start two important trials at AIIMS. PQQ is a molecule that comes out of bacteria. It's there in your gut. This is possibly the only source that you can have for PQQ. It stands for pyrroloquinone quinone. Very interesting molecule. Unfortunately, COVID came in the middle of the trial, and you can imagine how difficult it was to continue respiratory trials in the middle of 2020. So we don't have spirometry data, but if you only buy the quality of life questionnaire on people with COPD, it's a very positive result. But unfortunately, we did not have spirometry to show if there was any measurements. But that trial will be now done again, and also is being taken up for ILD. And so sometimes by taking the road less traveled, you see unexpected things. That is something that is very obvious. By looking at exhaled breath as a source of microRNAs, we published the first observation of microRNA signatures in breath, and now aims as a center for breathomics, taking forward some of these ideas. This time we've been, like I said, I was younger in those earlier findings. I was more senior towards the later part of the career. And we were able to convert some of these initial findings into clinical studies and centers. And Dr. Behera is one of the people who is evaluating those centers for us, and we look forward to his comments always. But microRNAs and other molecules, including volatile gas sensors, are part of what we do now. Partha talked about oscillometry. So we did some new things with oscillometry. Everybody measures R5, R20. We decided to look at them as time series signals and then apply mathematical analysis to see whether you can start separating asthma and COPD. And this work still hasn't fully completed, so many delays. But what you see is you can completely separate COPD from asthma. These triangles, by the way, are 30 people. So by using these mathematical analysis of oscillometry data as time series, we were able to separate these categories. This time we decided we will not just let it go into simple science. So we built, along with a company in America, Cognita Systems, the world's first FDA-approved portable handheld oscillometer. It's called PULMOCON. It has become now available in America, will come to India shortly. It should be much cheaper than most oscillometers, and pretty much is handheld, battery operated. So that is something, again, I believe when we add all these things onto it, might make a difference. So we are looking at those kinds of innovations. Tavpritesh is a medical doctor who decided to do PhD in my lab. He is now a professor at IIIT Delhi. So interesting journey, starting as an MBBS doctor from Patiala, coming to IGIB, doing his PhD with us. I originally hired an engineer to do this work. One day the engineer told me, I've been doing this mathematical work so long, I want to work with mice. And this guy comes up to me and says, I've been doing this biological work for so long, I want to do what that guy was doing. I said, fine, guys, work together, figure it out, cross over your projects. And Tavpritesh went on to learn statistics, programming. IGIB is a good place to learn these things. Went on to do all this work with the mathematical modeling, went on to win an early career fellowship at the Wellcome Trust DBT India Alliance, went on to spend a few years at Stanford, and now is back at IIIT Delhi, like I said. So again, these career tracks exist as an exception today. We need to make sure with many young people getting interested, we make them routine. That the story that I'm telling you is not an occasional story, it's an everyday story, not even worth telling, hopefully. So I'm going to end now by talking about there is no point of thinking about innovation if you're not aware of what is around the corner. Paul Valery talked about looking at the future like a man rowing a boat floating on the tide. You enter the future facing the past. What tomorrow look like, you don't know. But there are lots of things I can say should have been known. So for example, it's a new area of vaccines, right? All of you know that we have invented vaccines in record time, this time by mRNA technology. There is another quotation by William Gibson. The future is here. It is just not evenly distributed. Nucleic acid vaccines were invented in 1995. It's not a new thing. It spent a long time for people to recognize their importance. Deep learning, what we talk about all the time in medicine and AI. The original paper by Jan LeCun is in 1990. So deep learning, mRNA vaccine, this one was a DNA, but doesn't matter. Deep learning, nucleic acid vaccines are 20, 30-year-old ideas. People who are capable of knowing what is happening around them are capable of seeing the future and innovating accordingly. Looking forward then, for the next 25 years, what is the future of medicine? I'm not going to spend too much time. We're already running low on time, but big biomedicine. Reading, editing, writing genomes, all possible. P6 medicine, regenerative medicine, immunotherapies, brain-computer interfaces, all these things are coming. I'll give you only a few examples. Big biomedicine, I will not spend too much time on, but there are multiple now single cell level models starting to come up. Still difficult, but you want to understand the blueprint and the bricks of the body. It is now, you can create synthetic genomes. You can do editing-based correction of genetic disorders. We have already at IGIB built a brand new CRISPR for which IP is owned by India and is amongst the best CRISPRs in the world, published in the top journals in the world. And we have already taken Indian sickle cell disease patients, taken their stem cells, corrected their stem cells, removed this thing, shown that we can redifferentiate bone marrow progenitor cells from those stem cells. And now, because we don't have these things called humanized mice with human bone marrows, this part of the work, preclinical, is being done in University of Washington. But again, it's going to come back to India for phase 1s, and we hope to get this done. Already people in monkeys have shown that targeting PCSK9 can give you long-lasting reductions in cholesterol. Fully synthetic genomes are now possible. The entire E. coli genome can be now synthetically made. Sky's the limit in these areas. Mutating genes can become a therapy. I mean, this is the Nobel Prize that all of you know about by Charpentier and Doudna for their work, but less people know about this other work on PCSK9, but anyway, for some other day. I'm going to also skip past this. Data science will become tightly integrated into medicine. There will come a time within the next 10 years, people who don't understand data will have a hard time understanding the future of medicine. Again, very interesting work in case you don't know. If you were to try, if you take mice and tie together the circulatory systems so that a young mouse's blood flows into an old mouse, age-related impairment of cognitive function of the old mouse gets much, much better. It is an amazing paper. Young blood was sufficient to improve cognitive function of an old mouse. I mean, regenerative medicine will not get, and how it happens is now critical. Brain-computer interfaces. Now you are at the point where you can think about speaking. Let's say you have motor paralysis. You can no longer, you have lost your speech. But if your brain is able to think of how you used to operate your vocal cords, the computer can create speech from what you're thinking. Already happening. These are actual papers. And there are some very interesting ethically borderline works on pleasure centers and modulation of people, the Skinner box. Let's not get into them today. It's a very dual use technology, but really interesting. So I'm going to end by saying, if you want to ignite innovation, encourage young people to explore. Innovation usually occurs from the bottom of the pyramid, not at the top. If you encourage young people to get out of the well and explore, ignition and innovation will follow. Thank you all so much.
So what a wonderful talk. It's been fascinating, very encouraging. And I believe that the audience will remember Dr. Anurag for a long, long time to come. And a lot of things I hope will be happening, and many of us will be seeing what he has predicted. So I thank you from the core of my heart for this wonderful talk. And I'm sure the young people in the audience should be absolutely encouraged. So with this, let me go to the second part of the program today. And this is just a customary to have inaugurations. I'm lucky in that with me, I have got my chief guest present right now. He's Dr. Devashish Bhattacharya, the present Director of Medical Education, Government of West Bengal. To introduce him, let me be a little personal, because today it's all personal. I know my teacher, Dr. Behera, whom I've introduced. I know Anurag, good friend. And Devashish has been a bosom friend of mine from the college days. We were two together almost all the time, because his roll number was 29, mine was 30. We stayed in the same hostel. He opted for gynae ops, I opted for medicine. And he did MD from University of Pune. Then he did DNB, then he did PhD from Pune University. He was in armed forces for quite a good length of time. Then he came back and joined West Bengal Health Service. He was in teaching faculty, had been a wonderful teacher, a very famous teacher, and he has got a big fanfare amongst his students. So presently he's holding the chair of DME. I'm grateful to Dr. Bhattacharya, who has agreed to come as a chief guest of today's program. With me, we have got two other guests of honor, my beloved Professor Dr. Digambar Behera and Professor Anurag Agrawal. They have been our guests today, and we have listened to them and enriched ourselves. So I request them to be with me. And I also request Dr. Ganguly to be with me in today's program. So with this, without wasting any time, I would request all of my guests to just light the lamp and inaugurate the PULMOCON 2021. Let it be symbolic. So we are not been able to listen to the song of Tegor Aguner Poroshmuni Chua Prane. It is let the fire touch our souls and do the magic of changing us. Anyway, with this. So it's actually praying to the Almighty to make the meeting successful. So we hope that will happen, and we hope that PULMOCON will go very well this year. And with this hope, I request Dr. Acharya to say a few words in this August occasion.
It is really a pleasure to be here, Partha. And as you started that 29 and 30, we were together for a long time. It is nostalgic to have you here. And truly speaking, you have really become an institution as a single person and try to have a platform that so many great people can join together. And that is the need of the day to day. We should take this fire of our knowledge and break the walls in between us so that we can have a single platform where all of us can work together and bring up a new generation of science, the technology, the engineers, medical field, and each and every one of us, so that we can really bring a great India, and if not, we can give a really great thing to the world. I wish you and pray to God that this seminar becomes a really thought-provoking to all of us and generate a new generation for future. And wish, I pray, and I really convey my best wishes to you, Partha. I would have loved to hug you, but Corona is preventing us. So it is a really pleasure. Please carry it over and ignite your influence to your students, and let us all work together. Wish you all the best. Thank you.
Thank you very much. Sincere thanks. Now it is my pleasant duty to request my professor, Dr. Digambar Behera, to say a few words. He is a mentor of mine, and we owe a lot to our teachers, and because of them only we are here, and it is their legacy which we are carrying on. So, Professor Behera sir, would you please say a few words in the inauguration ceremony of PULMOCON 2021?
Yes, thank you, Partho. Dr. Bhattacharya, the other Bhattacharya, Professor Dhiman Ganguly, and Partho, Dr. Anurag, and dear friends, it is really a great experience to be with you in this inaugural ceremony. Partho, as a student, we had very great association at PGI Chandigarh while he was a resident in internal medicine, and then he came to our department as a DM student. But I think his inquisitiveness has still persisted. What mostly impressed me about, he, even if going to the private sector, he continued his research activity. Yes, it is okay. He was an eminent physician, chest physician, good knowledge, good clinical acumen. But I think being in the private sector and pursuing and continuing the research is one of the uh, special things which I have noted with Partho. And incidentally, although I know many of his work, his publication in high-end journals, having high reputation in the field of respiratory medicine, I had the opportunity of reviewing some of his projects, be it the ICMR or other agencies. So I'm really impressed, and Partho, good luck for you. Now coming to the PULMOCON myself, I think I had attended one of the his meetings way back in 2006. Then every year, of course, I come to know, I got invitation, see what is happening. And it is really over the years, he has, you have done very wonderful job. And I'm sure and another important thing which I have noted, that you have continued your association with the Professor Dhiman Ganguly. He is another encyclopedia in the field of respiratory medicine, and is so much of knowledge. I think that is another important quality of yours. Now coming to the respiratory medicine, as we all know, the respiratory medicine has undergone a dramatic change over the years. In our earlier days, and maybe Dr. Ganguly's days, when you see, our training was primarily TB centric. Then over the years, it became pulmonary medicine, respiratory medicine, critical care medicine. Many new things came in: intervention, pulmonology, sleep, critical care. Many things came in, lung cancer, many things came in, and gradually we forgot to about tuberculosis, which again, I think I talked and I told that I'm quite emotional about that. As the country now needs something like that. Many of our physicians, they have forgotten tuberculosis. It has come in a big way. There was nothing happening. We got the newer diagnosis. You see the type of development took place. It took a very long time, almost for 40 years, 30 years, nothing happened. No new drug, no newer diagnostic. The same smear AB, positive, negative, and then the culture, the standard culture. Then you see many things have come up, new drugs came in. Now it is very difficult even to keep pace with that. But on the other hand, now the country needs that, right? The country needs, again, we have to back to that. That will be one issue, and that at every stage, every chest physician should pursue that. Again, I had also hinted during my lecture how the TB training curriculum is totally silent, or maybe we are not. I'm sure we have again come back to that era if we want to, take care of this disease. And I think last point is about some newer diseases that have come to respiratory medicine, new viral diseases, newer diseases that came up and on. I think COVID-19 taught a great lesson to us. Even while there was COVID, I should not say there is COVID, and we do not know that it will still continue for how long. But even after COVID, even a chest physician will not be sitting idle. He has to handle the post-COVID issues, right? The fibrosis, the cough, the breathlessness. So all things will continue. And the last part of it I enjoyed the most is Dr. Anurag. I know that he's an intellectual. Maybe I will be nowhere in his intellect, whatever intellectual thinking, idea, knowledge he has got. But actually, really, it was very wonderful that you could get a man like him for today's talk. And it was really, I should say, it was wonderful. And I wish this conference a great success. And thank you. Thank you very much.
Thank you, sir, for your kind words. Now it's the fag end of the inauguration. May I request Professor Dr. Dhiman Ganguly to say a few words as vote of thanks.
Let me begin by thanking you for keeping me with you for all these 20 years. It's a long, long time. Today, there are plenty of platforms for chess physicians to discuss academic things, but 20 years ago, things were quite different when you started PULMOCON. So it gave a lot of young colleagues of ours a good platform to show their talent. So that was wonderful. And secondly, the next thing that was important is to develop a team of workers in your institute who would, keep the ball rolling. And so if you are asking me to offer vote of thanks. I think your workers and yourself, the Institute of Pulmocare needs a lot of thanks from all of us for being persistent with PULMOCON for 20 years. You see, usually our character is we begin things, but we cannot maintain things in the right way. So that's what you have been doing for 20 years. So that's wonderful. And secondly, keeping in touch with so many people, India is a huge country. And you have managed to somehow keep in touch with from Kashmir to Kanyakumari, from Gujarat to Assam. You have kept in touch with young, promising chess physicians and utilized them in this program every year. So that also is a great achievement, I would think. This year also, in spite of this COVID situation, I'm sure you will be able to sort of accumulate sensible, talented chess physicians to deliberate on different topics in pulmonology. I suppose this is going to be every Sunday, Patto. So,
yeah.
So let us, this year also, we keep the standard going, and hopefully by coming year, next September, we might have a physical meeting, God willing. Wish you all the best for the conference. Thank you.
Thank you. Thank you, sir.
Okay.
Thank you. So, thank you, Partho. Thank you, sir.
Thank you, Dr. Behera. Okay.
Thank you, Anurag.
Hopefully, we'll meet physically next year.
Yeah.
Okay.
Thank you, sir. Thank you, Anurag, for your wonderful presentation.
Thank you. My pleasure to be here. It was a pleasure.
Yeah. Thank you.
Sir, close Kochi, sir.
Yes, Kaushik. Thank you.